and then you can share with your colleagues, because I'm sure everybody's going to learn a lot with Dr. Silverman. Just remind you to save the date for August 27 to September the 1st, 2023. It's going to be the World Congress of Pediatric Cardiology and Cardiac Surgery. This is going to be amazing. Save the date. Congenital Heart Academy is an official educational partner of the World Congress. So we are having Dr. Anderson's series. Is very nice. Please join us on February the 4th. We are going to start the sequential segmental analysis of the heart. It's going to be in 2, maybe 3 parts. We are mixing some anatomical pieces with 3D CTs. Very nice. I'm sure all of you are going to enjoy. And we are happy to support the Da Silva Center for Aves and Anomalies Symposium. Is the second one. Is going to be on February the 12th on a Saturday. And Congenital Heart Academy is very happy to be a partner of them. Please join us. And today with you, we are going to restart this monthly meeting with Dr. Silverman, and I'm sure everybody is going to like it. And he's going to tell you about it, but he has his online book that is really, really worth to have it. I have it and I love it. Okay, thank you very much for you all to join. And Dr. Silverman, thank you for doing this for Congenital Heart Academy.
Pleasure. Thank you. So good morning, and thank you very much, Grace, for that very kind introduction. We're going to just start today on what we spend as pediatric cardiologists a great deal of our time with, and that's the functionally single ventricle. As Grace had mentioned, I have co-authors on this project, Dr. Bob Anderson, Dr. Philip Purcell, Diane Spicer, and Elena Kipps, and all of these people have made contributions to this chapter, which is available online at www.md1world.com. So what we have to do is first define what we mean by a single ventricle. And we don't like the term single ventricle. We like the term functionally single ventricle, as it more clearly describes what we're dealing with. This is the spectrum of congenital cardiac malformations in which the ventricular mass may not readily lend itself to a partitioning that commits one ventricular pump to a systemic circulation and another to the pulmonary circulation. Now, we're going to spend a lot of time on this. Today, we will try and talk about double inlet ventricle and tricuspid atresia, and in the following sessions, we will do these complex heart patterns. Now, in the 1850, Dr. Peacock came across a heart, he was a surgeon, of a child that passed away. And here is his etching from 1850. And this is the etching of the outflow tract. And I think that this is really quite remarkable, firstly, that it's so well dissected through the apex of the heart and on the outlet section, so that everything is displayed. And here we have some modern pictures from Bob Anderson's collection showing the interventricular foramen in this green cylinder, which will be used throughout this presentation. The septum is lifted forward. Here is the smooth upper border and fine crisscrossing apical trabeculations. And we look on the inlet, we see the atrial septum, the 2 atrioventricular valves draining into a ventricle of left ventricular morphology. So this, excuse me, is double inlet left ventricle. And the outlet chamber, you see here's the outlet chamber with the coronary arteries, as you see on the drawing over here. The interventricular foramen, not called a bulboventricular foramen, as this is the secondary interventricular foramen. And you can see the outlet here is rather coarse and has a septomarginal trabeculation on it. So this really is an incomplete right ventricle. It's incomplete because it doesn't have any AV valves draining into it. And what we're going to do today is we're going to look at the comparative morphology between the echo specimen below, the pathology example over here, which has been sliced in two ways. This is the back showing double inlet ventricle, and the front showing that the pulmonary trunk arises from this left ventricular chamber. And through the interventricular foramen, we see the small chamber here, which is the incomplete right ventricle, giving rise to a left-sided aorta. Here is a three-dimensional printed cast showing precisely the same features. A micro CT, which shows the actual valvar tissue. This is obviously from a specimen with double inlet into a morphologically left ventricle. A angiogram, which shows the incomplete right ventricle giving rise to the aorta, the interventricular communication, the pulmonary trunk arising from a ventricle of left ventricular morphology, and here in the black arrows, two AV valves draining into this ventricle, double inlet ventricle. And lastly, what we're going to compare these all to is going to be the echocardiogram, and we'll put this in motion. And here you can see two AV valves draining into a ventricle of left ventricular morphology posteriorly, a large pulmonary trunk here, giving rise to the pulmonary branches. And as we scan from back to front, we can see the various features of this morphology. So there are the two atriums. We see the right atrioventricular valve draining here. We see the left AV valve coming in here. Then we see the pulmonary trunk coming from the main chamber. The bulboventricular foramen, which we will never use again, we call it the interventricular foramen. You may call it a bulboventricular, but please try and call it an interventricular communication. And then the aorta arising from this little incomplete right ventricle. And I'll let that play just one more time for you so that you can see it. Now, when we approach this from an echocardiographic point of view, we establish the position of the heart within the chest, because it's not always in the left chest in this condition. We follow the sequential segmental analysis that Professor Anderson will begin to talk about on Friday. We establish the veno-atrial arrangement, the atrial arrangement, the atrioventricular connections, describe the ventricular morphology, topology, and position, define the morphology of the dominant ventricle as left or right or indeterminate, the morphology of the other incomplete ventricle, describe the ventricular arterial connections, the course and relations of the coronary arteries, which is helpful in defining ventricular morphology and is quite unique in this condition, and also the anomalies of the great arteries and their relationships. And that's what we'll talk about for the rest of this hour. So here in the parasternal long axis, we see these little yellow lines, which are the yellow lines of where the echocardiographic plane would be displayed. So the first, these, I won't say that anymore, but they will be on all of the morphology examples. So we take that off, and here we see the labels showing left atrium, pulmonary trunk, aorta, incomplete right ventricle, the right AV valve, the left AV valve, and this being the dominant ventricle. And then I'll let you look at that. And then we'll look at this CT scan from Dr. Tony Lavacek. And you can see here the same thing with a little bit of rotation as Tony has put on this here, showing the same features. And then the echocardiogram, which is oriented almost precisely the same way as the CT scan. And you see here again the interventricular communication, the incomplete right ventricle, left ventricle, and left atrium, and the atrioventricular valves with a small pulmonary artery coming from behind and a larger aorta in the front. And then in case you're looking at this on your phones, we will zoom this up for you. I'm sorry, I've moved that off. I don't want to go back. Now, in short axis, we look at the scan at the level of the great arteries, and we see the great arteries here. And here you can see the pulmonary trunk posteriorly and the aorta anteriorly, the aorta rising from the incomplete right ventricle, excuse me, and the anterior interventricular artery, which separates the morphologically right from the morphologically left ventricle. But we're looking here at the great vessels. And here you see the aorta anterior and to the left, the pulmonary artery posterior and to the right. And we can see the coronary arteries coming off these on a number of occasions. Now, when we look at the vessels, they're not always equal in size, and there are often problems with the semilunar valves. And so here is a patient who's got a partially fused valve, which isn't opening very well. And of course, as this is developed in utero, the flow has been low, so growth has been somewhat restricted in this vessel. We can also look at these vessels in these positions and look at the coronary arteries. And here you see a long left main coronary artery dividing into the left anterior descending, or as we call it, the anterior interventricular artery, and the circumflex artery as it runs posteriorly. And now, in case you're looking at it on a smartphone, here you see all of these things have been zoomed up, and these will all be done like this at the end of the description of this work, to show you this and not have you strain to look at small images on a smartphone. Now, when we go in the short axis here, oriented with a double inlet ventricle with subpulmonary obstruction and a small pulmonary trunk, you can see on the echocardiogram the same features, and that is a small pulmonary artery posteriorly and rightward, a large anterior aorta leftward with coronary artery arising from it. And in this patient, a stent was placed in the pulmonary artery to improve the flow into the branch pulmonary arteries. So we can see all of these things as we examine these patients with this complex anatomy. Now, if we move the scan from above downwards to the level of the ventricles, we see a very important feature in double inlet ventricle. And that is something that you can't see on the outside, of course, but you see two atrioventricular valves with an absence of septum between them, so that these valves actually kiss each other during the course of diastole as they open up. And that indicates that this is a morphologically left ventricle with two atrioventricular valves draining into it. How do we know it's a morphologically left ventricle? Because we will also feed the incomplete and superiorly related anterior incomplete right ventricle. Now, when we open this up, we can look inside at the short axis through the level of the atrioventricular valves. And you can see that this is compared to the oval fossa. We can see here the small right atrioventricular valve. I think this is a quite unusual specimen, and I've used it several times during this presentation because the right atrioventricular valve is small. And when we go in the short axis in a double inlet ventricle, you can see this small right atrioventricular valve with tendinous cords flapping around compared to the much larger left atrioventricular valve, which is present in this patient. So the other point about making a distinction of looking at the atrioventricular valves is that these functionally single ventricles, if they have two AV valves in double inlet ventricle, it's not always like a spare tire that you can just simply change it or work it around, that there often are abnormalities of both atrioventricular valves, and that will determine the prognosis. Now, here's an unusual form of double inlet ventricle. It's double inlet into a ventricle which maybe looks left, maybe looks right, Here, the outflow tracks into the aorta and the pulmonary artery from below, cause trabeculations, fine, smooth upper border trabeculations, so we can't make the anatomy, so we call it an indeterminate ventricle. And there is a complete atrioventricular valve or a common AV valve draining into this morphologically left ventricle. And there is the common AV valve draining into the morphologically, what looks like on the echo, much more characteristic of the left ventricle. And there was obviously also a smaller ventricle, which I did not put out over here to show you as well. So double inlet ventricle with a complete common AV valve draining into the left ventricle, indeterminate ventricle of indeterminate morphology. Now, when we look at the original echo that we've seen over here, and we slice it through this way and look at it in a 4-chamber cut, we can see the left and right atriums, the 2 atrioventricular valves, which are at the same level because there's no membranous septum in this area or inlet septum, the fine crisscrossing apical trabeculations. And on the echocardiogram, an almost perfect comparison between these 2 examples. And there you see left atrium and right atrium and the morphologically left ventricle with 2 sets of papillary muscles and no evidence of a ventricular septum between them. And also that both atrioventricular valves in this young child are already leaking. And as you know, chronic AV valve insufficiency really will functionally impair ventricles over a period of time. So there's the zoom comparison showing the beautiful comparison between the echocardiogram and the morphology. And we've done this with 2 other techniques. Here's the micro CT showing the atrioventricular valves, the CT scan, which doesn't show that quite so well, but shows the morphology very well. And I've matched that with the same specimen, so there's really no difference over here. And again, this was provided for me courtesy of Dr. Tony Lavache. And there's the zoom for you. Now, here are some other examples. Here's a little bar, which is often present. It doesn't mean it's a ventricular septum. It's a common feature of double inlet ventricle. And you see here the intraventricular, the inferior caval vein draining into the right atrium. Here's the atrial septum. And here you see the 2 AV valves draining into a ventricle clearly of left ventricular morphology. This is from a fetus where the morphology of the ventricles is not so well developed as it is after birth. Here's the oval fossa, left atrium, right atrioventricular valve, left AV valve, draining into a ventricle of left ventricular morphology, and the incomplete right ventricle is in the other half of the specimen. And now here we're going to do a scan from low to high on this example here. And here we will begin with left atrium, right atrium, and morphologically left ventricle. And then as we come cranial through this, we can see the whole thing. What I'm going to try and do, I'll stop this here, and I will move this here so that you can see the scan as it goes forward. 2 atriums. There's the left AV valve. The right AV valve is, the right AV valve. The left AV valve is in here. It's a little hard to see. We'll see it coming from time to time. Then you see the pulmonary artery coming from the left ventricular chamber, the interventricular communication, and the incomplete right ventricle, which as we go cranially, there you see the other AV valve just over here, pieces of it coming in. And then as we come forward, we see the aorta arising from that main chamber. So we'll put this in play, and we'll put this down here and watch the scan one more time from low through to the left ventricle, the ductus, the right ventricle, incomplete right ventricle, giving rise to the aorta anterior and leftwards. And we can compare this to to magnetic resonance imaging. And here's a three-dimensional printed model showing the same features with the incomplete right ventricle and the interventricular communication. The right coronary artery is seen running off here. Here's the right coronary artery again on the echocardiogram. And you see again this interventricular communication with the incomplete right ventricle arising from it and giving rise to the aorta. Now, Doppler color flow is very important because this is a critical issue in terms of size, because if it's too big, of course, that's one issue. Usually the vessels are not normal. So if there's a lot of pulmonary, flow going in this direction, the pulmonary artery doesn't develop. If, of course, it's restrictive, as it is in this example here, underneath the bulb of ventricular foramen, then, of course, there's a velocity gradient here. There's a larger pulmonary blood flow here, which is now being curtailed by means of the pulmonary artery band, and the aorta gets less flow. And this is associated either with aortic arch interruption or with coarctation of the aorta. So when this measurement that Dr. Steve Sanders and I did independently in two different research studies is under 2 centimeters per meter squared of body surface area, you have to watch out for the presence of coarctation and aortic arch interruption as an issue. We'll get to see more of that. And here, of course, is the aortic arch from the suprasternal notch, showing an area of coarctation. And we'll just put this in play for you. And there you see the arterial duct. You see the coarctation with the isthmus, and clearly there's a constriction at this level. And we've oriented the specimen now, so it's exactly aligned with the echocardiogram. Now, when we talk about AV valve abnormalities, we've already shown you hyperplasia. We're going to talk about straddling, stenosis, insufficiency, and atresia of the AV valves. And we'll start off by looking at straddling. And here you see a beautiful example of double inlet left ventricle with the right atrioventricular valve just straddling over this morphologically right ventricle. Here's the atrial septum, and this is a classical feature of straddling valves, is the malalignment between the atrial septum and the ventricular septum. So this is classical of straddle. And when that happens, of course, then the valve is going to lie over the two ventricles. Now, this one you could call double inlet ventricle, as we could call over here. But look, the same malalignment between the atrial septum and the ventricular septum is absolutely evident. And the AV valve is also straddling on this echocardiogram into the morphologically right ventricle. And here you can see some chordae tendineae coming in here. Okay, there's the straddle, same as the specimen, but with some tendinous cords going into the ventricle. Now, this is a complicated drawing. They're obviously obtained from the same way. The specimen is opened in its midsection. So this is the front part, and this is the back part. I'm going to take off the fans, and you can see, looking here at this, is a left ventricle, has a interventricular septum, has an incomplete right ventricle, and shows straddling of this atrioventricular valve, the left AV valve, into the incomplete right ventricle. The right AV valve drains into this dominant left ventricle, which also receives most of this. Now, this is a very complicated slide, so we'll just show you that this is the same orientation. Here's the incomplete right ventricle. Here is the straddling valve, and there's another atrioventricular valve here. I'll take the, and when it's moving, it's much easier. There's also subpulmonary obstruction in this patient. And here you can see the straddling valve going from the morphologically left ventricle to the incomplete right ventricle. They're the two AV valves. So all four AV valves are shown. And here's the right AV valve, entirely separate and draining into this ventricle of left ventricular morphology. So double inlet with a clear example of straddle. The straddle is even attaching to a papillary muscle in this incomplete right ventricle. And once again, the straddle and the other AV valve here. Now, when we look at the valves, we can look at the valves from the atrial surface. And here's a patient from my archive, which shows a very small mitral orifice, but with a ring of tissue. And I always get my students to put their finger in this ring because it's just like a ring. It isn't at the annulus of the valve, but it's mainly within the atrial surface of the left AV valve. So this is a supravalvular ring, and you have to have a high index of suspicion for this particular abnormality echocardiographically. Now here's the same heart from below, showing a solitary papillary muscle from this left atrioventricular valve orifice. Here's the right AV valve orifice on this side. And of course, there's double inlet into a ventricle of left ventricular morphology. Now, echocardiographically from the subcostal coronal cut, we can see these features. And you can see on motion that this valve has got like a funnel in it. There's the upper part of the funnel, and then the valve moves in a parallel fashion, suggesting, as we found later, that this was a supravalvular mitral ring. And the mitral valvular ring tethers the AV valve at the point of its maximum opening. Let's just put this into play. There it is. And this is where the ring is. Here's the upper part of the AV valve. There's the ring. And of course, then the valve doesn't open like a normal valve, but opens in a funnel shape appearance. Now, straddling is very common, and here is it makes it, of course, impossible to septate these ventricles. But here you see the right atrioventricular valve straddling into a morphologically left ventricle. Okay. And here you see the right AV valve straddling into a morphologically left ventricle. This is the interventricular foramen, always in green. And now we'll look from above at a classical example of straddling, which shows the malalignment between the ventricular septum and the atrial septum. There's an atrial septal defect, and we're looking at the right atrioventricular valve, which I've called tricuspid here, and the left AV valve here. And if you just look in the yellow circle, what it looks like is that this is like an AV septal defect. There's the bare area of the septum. There's the mural leaflet. And here's the anterior bridging leaflet, which is attached to the crest of the septum. And of course, if you don't recognize the other AV valve, and because echocardiographic planes show malalignment between the atrial septum and the ventricular septum, as you can see here, almost at 90 degrees, when you look at one, you won't find the other. When you look at this septum, you won't see this septum because they're in different planes. And this really looks like an AV septal defect. Now, if we turn this heart round and look at it from the right side, you can see here is the right ventricle. There is a straddling valve going into the left ventricle. This is the plane of the interventricular septum, and this is the plane of the atrial septum. Those are planes of the two septums. And now when we look at the echocardiogram, what we look at is, when we're looking at this here, is we see what looks like an AV septal defect. And remember that an AV septal defect valve that straddles the ventricular septum is an exemplar of a straddling valve. And so here this looks like no atrial septum. So you think, oh, well, you're dealing with ostium primum ASD, very large ostium or absent atrial septum. But the atrial septum is running in a different plane, and you have to turn the echoplane round in order to see this. So you have to look for this whenever you see something where you think, aha, this is just simply an AV septal defect. You'll see in the subsequent frames that this is a double outlet right ventricle with a separate secondary atrioventricular valve. And you have to go and look for it. You cannot see it here. Okay, so there you can see it once again in zoom mode. And here's a second specimen. This is from Dr. Spicer's archive. And you can see there's the ventricular septum. Here's the AV valve. And you look from above, this is the right atrium. There's another atrioventricular valve here. So this valve is straddling into the right ventricle. Here's the ventricular septum, small left ventricle. Here's the valve straddling across into the right ventricle. There's the aorta coming from this vessel and a pulmonary artery band which has been opened. And here I've just turned the previous echocardiogram around and looking at it in a subcostal coronal cut. And here you can see the straddling valve with these arrows. And there's another AV valve here. Let's just take the labels off and you can see that. So here's the straddling valve, straddling across from a morphologically left ventricle into a morphologically right ventricle. And here is a separate AV valve draining into this right ventricle. And here we'll see the great vessels arising above this heart in double outlet right ventricular fashion. And there it is, just magnified up so that you can see this beautiful example of a straddling valve, the same straddling valve as in the previous example. And there that looks like, oh, this might be a semilunar valve, is not a semilunar valve. It's opening simultaneously with this valve. And that is the second atrioventricular valve, draining exclusively and supported exclusively in this right ventricle. Now, there are many other examples. Here's another example of a right AV valve straddling in the subcostal sagittal cut across the ventricular septum with papillary muscle attachment on both sides, with the left AV valve exclusively situated in the morphologically left ventricle. And looking from the frontal plane, here you see the two AV valves with the right AV valve straddling, and it's supported on the right ventricle and on the ventricular septum. And here's the aorta in the middle with the coronary artery arising from it. So a beautiful example of a straddling right atrioventricular valve. Now let's look at the incomplete right ventricle and the interventricular communication, which we have to evaluate. We've seen this example before and the echocardiogram, and this shows the interventricular artery, okay, over here, anterior interventricular artery. So this is a right-sided outlet chamber, right-sided, I beg your pardon, left-sided outlet chamber. So sorry, left-sided outlet chamber. There it is. And we've seen that picture before, so I won't go and disturb you any further by belaboring it, but the outlet chamber is clearly left-sided. And here is an example of the anterior interventricular artery with a right-sided outlet chamber. Clearly, this is a right ventricular morphology giving rise to the aorta. Here's the aorta, here's the right ventricle. So this could be an example of tricuspid atresia with transposition, but there were clearly only one AV valve in here. So like this could be some construed as tricuspid atresia, and we'll go and explore that a little further. But if there's double inlet here, this is as there was in this patient, I'm sorry, this is a double inlet ventricle with a right-sided outlet chamber. So I'm highlighting the position of the outlet chambers could be either right or left. And the bulboventricular foramen may be restrictive. Here's an example of a restrictive bulboventricular foramen. We're looking just at the right ventricle. There's obstruction within the right ventricular outflow tract and leading to a small aorta. Compare the size of the aorta to the size of the pulmonary artery. And here on the echo, you can see the small interventricular communication, incomplete right ventricle, and small aortic valve with what looks like an incomplete aortic arch. Now, obviously, you can't see the aortic arch because it's running in a different direction. So we simply take this picture and we turn it around. You can see the electrocardiogram is the same. And what you see here when we put the color on is you see that there is an interrupted aortic arch, a large pulmonary artery with an arterial duct going into the descending aorta. So the right ventricle is extremely small and restrictive here. Now, this is certainly going to be a Damas type repair with pulmonary artery banding and almost a Norwood procedure here. Here's another example just to show you the interventricular communication and the color flow accelerating across the outflow tract. And then, of course, you can measure the velocity coming across this area here. There's also subpulmonary obstruction, which makes more blood force across there. And there is a gradient here on continuous wave Doppler of 34 millimeters of mercury. Now we've opened this heart in clamshell fashion to show subpulmonary obstruction. I think it's best if we take the labels off. And here you can see a ridge of fibrous tissue underneath the pulmonary trunk, which is arising from this ventricle of left ventricular morphology. Here's the ventricular septum. Remember, if you close this, then the ventricular septum is running over here. Here's the interventricular communication. And here, coming off the anterior vessel, is the aorta. But what I want to bring out to your attention is the various complex nature of the subpulmonary obstruction. And you can see this beautifully on the echocardiogram, because here's the pulmonary artery with the pulmonary valve. And there is the long segment of complex pulmonary stenosis in this area. And I'll take the labels off so that you can see that. And look at it again in a parasternal long axis. And here you can see a deviation of this outlet septum, a narrowing, an abnormal valve, and poststenotic dilatation of the pulmonary trunk, which is lying posterior and to the right of the aorta. So the nature of the subpulmonary obstruction has to be investigated. It's almost impossible for the surgeon to get to it. It's in the middle of the heart. You can't get to it from the AV valves, and you can't get to it from the arterial valves either. Double inlet with the incomplete right ventricle and normally related great arteries. This is the great unifier and understanding of the structure that I'm going to show you. And this is the Holmes heart. It ties tricuspid atresia to double inlet ventricle. And this is the heart that exists in the archive of the Montreal Children's Hospital, established by Maud Abbott in 1936 in her volume. And this is the original heart. And she's shown us, this is the pulmonary outflow tract. She's showing us double inlet into the left ventricle. Here is the aorta, Here's the little outlet chamber going into the pulmonary artery. And this is pulmonary artery here. The aorta is running behind this over here. And here is the right atrium. So let's take the labels off. And you can look at this and follow this with here. The drawing is really quite beautiful. Here's this little bulboventricular foramen here. And this is the outlet into the pulmonary artery here. The aorta is coming behind the left AV valve and going into the other part of the aorta above here. So what we have here is double inlet left ventricle with the aorta coming from the left ventricle, a small interventricular foramen, a large pulmonary artery going into the pulmonary branches. And this is the Holmes heart, named for the predecessor of the curator of the museum in Montreal. And here you can see double inlet left ventricle with normally related great vessels. And here is an example here. You can just see the other AV valve here. We're a little bit too far forward to see it, and I didn't have a sweep to show you this. They are not common, but here clearly the aorta is arising from the left ventricle. You can even see the coronary arteries here. The pulmonary artery is not shown, but it's coming from the right ventricle here. And there's double inlet into a ventricle of left ventricular morphology. There's the other AV valve there, which you can't see, coming from the right atrium, from the left atrium. So this is the classical Holmes heart. And here's another example of the Holmes heart. I think the labels get in your way. Here is the left ventricle opened in clamshell fashion again, showing the interventricular communication. And this is the left ventricle, which has got two AV valves draining into it, albeit that some of them attach to the crest of the ventricular septum. Here's the smooth upper border. And here is the incomplete right ventricle, which shows you this ventricle here when it's put back into place, the AV valve here. And you see here on the echocardiogram very beautifully, you can see that there's clearly double inlet into this ventricle of left ventricular morphology. The aorta, with its two coronary arteries, is arising from the left ventricle, and the pulmonary trunk is coming from this anterior right ventricle, which is not shown in this particular example. So this is an example of the Holmes heart. And here's another one where the aorta is very small because the interventricular communication is small. And that looks very much like it could be tricuspid atresia, except there are two AV valves draining into the ventricle of left ventricular morphology. So the only difference between this and tricuspid atresia, when you look at the front part of the heart, is there's no difference, except that in tricuspid atresia, there's only one AV valve draining in here, and in the Holmes heart, there are two. We'll get to see that in a moment, but here we're looking at the example of mirror imaged arrangement, where we see the aorta anterior and to the right, the pulmonary artery posterior to the left, and the morphology of the ventricles is still left inferior and right superior and anterior, with the apex pointing to the right, and the atriums in situs inversus. So if we follow segmental sequential anatomy, we have no problem with these examples. And here you'll see the example of the double inlet into this morphologically left ventricle, big pulmonary artery here. And on this example, obstruction underneath the pulmonary artery and the small aorta in the front here. Double inlet into the ventricle. The AV valve is obstructing the left ventricular outflow tract. And again, there's asymmetry in this example of the two AV valves, with a larger right AV valve and a much smaller abnormal left AV valve, almost parachute in its characteristics. And here is an example of double inlet right ventricle with a diminutive left ventricle with the interventricular communication showing the small left ventricle here in what we call the hip pocket left ventricle. Okay, and there's double outlet from the morphologically right ventricle. Double inlet, you can't actually see that, but you can on the echo, but you can actually see on the echo where the interventricular foramen is. You see this is clearly a left ventricle posterior and the right ventricle anterior. This is front and back. Okay. Okay, and I've rotated this round so that it's oriented in a similar fashion. But this is really posterior and inferior, and this is anterior and superior. And it's done in this sort of plane. And here's the back half of the specimen here. And there is the left ventricle with the smooth upper border and fine crisscrossing apical trabeculations, a small left ventricular cavity with the left AV valve barely straddling into this ventricle through an interventricular foramen. And here we'll see on the echo a very complicated look at the echo. You see there's one AV valve straddling into this little ventricle of left ventricular morphology. Okay, then there's the other AV valve. There is double outlet into the right ventricle. This is the pulmonary artery, which is stenosed, but still has a band on it, and a larger aorta, which is seen anteriorly in the front. So this is back and left, front and right. I'll let you look at that in a large example. There it is. Pulmonary artery, domed and stenotic, a band nevertheless. Morphologically left ventricle, morphologically right ventricle, two AV valves draining into this morphologically right ventricle, little straddle of the left AV valve into this hip pocket left ventricle. And here's the same heart on echo looked at in two different planes. And here you can see on the morphological specimen that this is a morphologically right ventricle with two AV valves draining into it with coarse apical trabeculations, as we see here on the echo as well. Double inlet into this ventricle, which we've called morphologically a right ventricle, because we saw where the left ventricle was. And here is that same left ventricle again. And there is the little left ventricle. And then here are the two AV valves. There's the pulmonary valve situated between the two. There's the band. There's the stenotic valve. And here's the aorta. So double inlet, right ventricle, a small hip pocket left ventricle, and double outlet right ventricle with pulmonary stenosis, but with the pulmonary artery band. And we've seen this picture before. This is just an indeterminate ventricle with a common AV valve. I'm going to move on, and let's talk about absent left atrioventricular connections. In the univentricular atrioventricular, there's no connection between an atrium and a ventricle. When this occurs on the left side, we term this mitral atresia. When it occurs on the right side, we term it tricuspid atresia. The following examples of this echomorphological correlation. Now, you remember the classification of Edwards and Burchell from 1949. We're still using it. Type 1A with normally related great vessels, closed ventricular and pulmonary atresia, rare to see this. Type 1B, much more common with a small ventricular septal defect. It should be interventricular communication, but they didn't have that terminology in 49. Subpulmonary stenosis and pulmonary hyperplasia, and the less common one with a moderate to large ventricular septal defect with subpulmonary stenosis and pulmonary hyperplasia. So in type 1, there's always pulmonary problems. Type 2 is transposition of the great arteries with pulmonary atresia and ventricular septal defect, with pulmonary and subpulmonary stenosis, and without pulmonary stenosis. And there, of course, is a type 3 which is congenitally corrected transposition of the great vessels. So let's look at some classical tricuspid atresias. On morphology, you'll find this little sliver of a ventricle, which is a right ventricle, unquestionably, because there's the left. Here's the anterior interventricular artery. And the right atrium has no contact with the left ventricle, is entirely absent connection. Here's the aorta. And here's an echocardiogram showing you that feature here, that there is no connection between the right atrium and the right ventricle. The ventricle is filled through this interventricular communication. Here's the large left ventricle, aorta, normally related great vessels with a small pulmonary artery, what we would call the 1B. And if we take this picture in the coronal and turn it into subcostal sagittal cut, we get to see this here. And here is the right ventricle in the front. So this is front and back, anterior, posterior, superior, inferior. And you can see the subpulmonary obstruction here into the pulmonary artery. And I think you can also see that there's a little ductus. And that's very important. I may not have time to describe that, but the duct is one of the things that confounds you about pulmonary atresia, about tricuspid atresia, because if this closes, the vital amount of oxygen which is allowing this child to survive may be removed, and then of course you get a hypercyanotic spell with all kinds of chaos occurring and emergency surgery. So this is the small right ventricle in the front, the large aorta compared to the size of the right ventricular outflow tract, and the pulmonary artery above. So tricuspid atresia type 1B. Now what I wanted to do is show you this classical feature of tricuspid atresia, because I think the neophytes, and there may be some young people in the audience here that don't know that really what tricuspid atresia is an absence of the connection between the right atrium and the morphologically right ventricle. And I'm going to stress this in this presentation. So here you can see in the right AV groove, this beautiful right coronary artery, which is the only thing that lies in the groove between the right atrium and the right ventricle. There is no connection between the right atrium and this right ventricle. And I have an echocardiogram here to show this with saline contrast flush. And you can see first the right atrium, then the right to left atrial shunt, then filling of the right ventricle, and then filling across the interventricular communication and into the complete right ventricle, and then into the pulmonary trunk last. So here you go. I'll just zoom that up for you just so that you can see and stress once again in black and white the absence of the connection between the right atrium and the underlying right ventricle. And here's a morphological example showing this again, the floor of the right atrium, the Eustachian valve, the left atrium, the terminal crest over here. And here you see coronary arteries lying in the groove, separating this from the underlying morphologically right ventricle. And we see this on the echocardiogram as well. Here you can see the atrial septum bulging from right to left atrium and a small interventricular communication. This is a large Eustachian valve, which is frequently present and which some people call quadratum dexter. Perfect comparison. Absence of connection. So this is the usual form of tricuspid atresia. And when you look into the right atrium, you can see the oval fossa. You can see this little dimple here. This dimple is where the tricuspid valve would have been. Okay, there's the dimple. Now, if you take a pin and you put it through the dimple, it comes out in the left ventricle, almost reminiscent of double inlet ventricle, but with an absent connection. Here's the incomplete right ventricle, and there's no connection between the right atrium and the ventricle. So once again, an absent connection, and I've put this together with a short axis picture to show the ventricular septal defect. You can see the right atrium has no connection to the right ventricle. And there's also a quadratum present, or a divided right atrium present in this heart. But we want to really focus on the features that show the dimple not being associated with this ventricle. And I have one example even in a fetus. And here's a fetal example from Andrew Cook in London, showing the right atrium and the floor of the right ventricle with no communication, just epicardial fat in this region, which is, of course, quite limited in the fetus. And here's the sliver of a right ventricle with a cartoon and an echocardiogram showing again that the features of tricuspid atresia are an absence of the connection between the right atrium and the underlying right ventricle. And I've zoomed that up for you. This is a fetus, very, very small, 20-week fetus, already with clear evidence of an absence of the connection between the atrium and the ventricle. Now, the ventricular communication may vary in size. We saw small. This is the next size up, which is a moderate one. There's the interventricular communication. And here it is on the echo in black and white and in color, showing a left to right ventricular shunt as part of the last part of that complex. And here's a large interventricular communication. So this is a kind of patient that may actually have had heart failure in association with tricuspid atresia, type 1C, tricuspid atresia, albeit that they have subpulmonary and pulmonary stenosis. And here you can see a much larger interventricular communication. Here's this divided left atrium, which I've used this example, has beautiful pathology in it. There's the interventricular communication, and what you can't see is a large amount of left to right shunting here because the pressure in the ventricles is the same. And here's a large ventricle, again with normally related great vessels. There's the interventricular communication. Here's the interventricular communication. Look how much larger the right ventricle is in this particular example. And when we turn it around, we can see huge pulmonary artery here, very little in the way of infundibular obstruction. Left atrium to left ventricle, interventricular communication. Okay. Now, this is everybody's concept, a beginner's concept of tricuspid atresia. This is a very, very unusual form of tricuspid atresia. The tricuspid valve was formed, but is atretic. And this is looking at it from the atrial surface. There's the coronary sinus. There's the coarse trabeculations of the atrium. Here's the oval fossa. And right here is a small tricuspid annulus with a membrane across it. And when we look at this and section it in four-chamber view, you can see that there is some blood that has filled this ventricle, but there's also papillary muscles and tendinous cords here, but that this vessel is entirely, this valve here is entirely atretic. Here's this Eustachian valve that we saw before, the terminal crest, and the coarse pectinate muscles. And here we're looking on the echocardiogram at an example of a membranous atresia. There's just a fine membrane across there. This has to be distinguished from a mildly imperforate valve, which is the next step up. Okay, so this is everybody's concept of tricuspid atresia, but this is the rarest example that you will find a membranous atresia of the tricuspid valve. It is much more frequently an absent connection. And this is just the outflow tract. I'm going to skip through this quickly. It shows nothing we haven't seen before. So let's tie up tricuspid atresia in the Holmes heart. Here's the Holmes heart, double inlet ventricle, okay, with the pulmonary trunk coming off the incomplete right ventricle. The aorta coming from the left ventricle. So normally related great vessels. And here's tricuspid atresia. The outlets are identical. It's merely the inlets that are different. This is double inlet, and this is tricuspid atresia, or absence of the right connection. So double inlet connection, absent right connection. Okay? I'll take all the labels off for you, and I can zoom in a little bit, but it's gone. Okay, now we talked about this being an atretic valve. Here's an example of, I showed you before this example, and here it looks like this could be tricuspid atresia. But no, you can see there's actually flow across this valve. So this isn't tricuspid atresia, it's a hypoplastic left AV valve, which is perforate. Now, the other lesions associated with tricuspid atresia are varied, okay? Common arterial trunk, interrupted aortic arch, patent ductus, AV septal defects, anomalies of cardiac position and arrangement, mitral valve abnormalities, juxtaposition of the atrial appendages, and many, many other lesions. So here is an example of transposition associated with tricuspid atresia, the type 2. Okay, and type B, and you see here, here's the pulmonary artery with a band on it. Here's the incomplete right ventricle with the interventricular communication, and the aorta arising from it. So this is the morphologically right ventricle, incomplete as it is, and there is an interventricular communication and a large left ventricle which was draining into the pulmonary artery. So transposition of the great arteries. And here is the live example from an echocardiogram showing the pulmonary arterial band, the pulmonary arteries above it. There's the interventricular communication. And here is the pulmonary artery arising off this left ventricle and the aorta from the incomplete right ventricle. And this is an apical, a subcostal coronal cut here with some mesocardia. And then if we turn this probe round in 90 degrees, we can see the same features here. I'll just take the labels off. There's the aorta coming from the incomplete right ventricle. Here's the interventricular communication. There's the morphologically left ventricle receiving the mitral valve and mitral pulmonary fibrous continuity, indicating that this is transposition of the great arteries. This is a common abnormality found in tricuspid atresia. It is juxtaposition of the atrial appendages, the right and the left. Now, the right atrial appendage swivels over and joins on the left side here, and it pulls with it the atrial septum. You can see that the aorta is dextroposed and the pulmonary artery levoposed. And here is such an example showing a restrictive ventricular septal defect here, morphologically left ventricle, dextrocardia, as you see it here, and the small aorta above here. And I've just zoomed in on this so that you can see it with color flow, showing the VSD and the flow going out there. And there also looks like there's some form of shunt going on in this heart as well. Surgical shunt, that is. Now, here's another example, and it shows you that there is also a duct problem and what looks like an arch problem as well. Here is the apex on the right side, okay? And here's the morphologically left atrial appendage in its usual position, and the right, which is swiveled around the back of the great arteries and is coming to lie above here. And you can see that if when you do these pictures, this is front and anterior, and this is back and inferior and posterior. And so it's very difficult to see the two of them. The secret is that the atrial septum is deviated as well because of the fact that the appendage is moving around here. So there are two pictures that are showing the atrial appendages, and they're clearly different in their morphology and the character. This is a long, scraggly, narrow appendage. This has got a wide attachment to the appendage. Okay, so there's the appendage here. I'll take that off. Here's the atrial septum, and the right atrium is straddling behind the valve and is attaching here. This is the key picture. The question is, where is the left atrial appendage? And here is the left atrial appendage that you can see with the dextrocardia, that this appendage is a narrow, swiveling appendage that goes out on this side. Here, the right atrial appendage is above and not seen. The atrial septum is swiveled over. Here's the oval fossa. This is the small left atrium with this narrow appendage draining into the ventricle, into the body of the atrium. This is another common anomaly in tricuspid atresia, is that the valve somehow doesn't form properly. And this is a patient with tricuspid atresia who's got a so-called cleft in the mitral valve. In fact, the right AV valve, the left AV valve, I beg your pardon here, the mitral valve is cleft. It's almost tricuspid in its nature, superior bridging leaflet, inferior bridging leaflet, and Lagen, and mural leaflet here. So this is not an uncommon abnormality in tricuspid atresia. And here you can see the superior and inferior bridging leaflet and the mural leaflet here. I'll show this to you. This is the same patient, same electrocardiogram, as you can see. Here is a parasternal long axis with the cleft and the attachment to the crest of the septum here. And here is the short axis of this morphologically left ventricle. This is all left ventricle here. There's the superior bridging leaflet. Here's the inferior bridging leaflet. And here is the mural leaflet there. And I'll take the labels off for you here and zoom in so that you can see that. So there's superior and inferior bridging leaflet and mural leaflet. Superior and inferior bridging leaflet and mural leaflet. Superior, inferior, mural. And I still have the power to stop this. And there we can see all three leaflets. Caudal attachment to the crest of the septum, superior, inferior bridging leaflet, and the mural leaflet. Here's another such example in tricuspid atresia from the Pittsburgh archive this time. And there again, you see the large interventricular communication and the so-called cleft, which is really a commissure between superior and inferior bridging leaflets. And here, once again, another example of a divided left atrium, what we call divided left atrium. This is the proximal distal end mitral valve. And this is tricuspid atresia. Once again, we've seen this specimen before. There's the foramen ovale going to the back. There's the divided fibrous partition, as we call it. DFP stands for divided fibrous partition. And here you see the flow to and fro across this mitral valve. So the only mitral valve, the only valve that this patient has in the atrioventricular position already is beginning to leak as a neonate. So there's the divided fibrous partition there. And this is tricuspid atresia. Now, my last slide, and I thank you for your attention, is just to remember once again the pattern of tricuspid atresia, in tricuspid atresia, the importance of this valve, because the patient may look relatively good, even though this is a small amount of blood flow. It's enough to keep the patient from being extremely cyanotic, but it's not enough for you to dismiss this patient and bring them back at 3 months for a Glenn procedure or something like that. this can lead to a problem, and it may be wiser to stent these patients at this stage rather than to just leave them. So I think that's the end of the session for today. And we'll discuss in the next month, I think on the 1st of March, we'll discuss hyperplastic left heart. Okay, so thank you very much for your attention. And I'm going to stop sharing my screen. And I'm going to look. Thank you.
Thank you very much. I don't have words to add about your speech, because I think that in this hour, all the people that follow us was able, to check a unique opportunity, anatomy and echocardiography. I think that is real useful for clinical practice. So I have a lot of people who thank you, but on the question, answering question, I think we have one question that is interesting.
Yeah, I have a question from Dr. James Thompson, a former fellow of mine, who says, how do I know that is the would-be tricuspid valve rather than AV septum? And I don't know if you could rewrite that, Jim. I'd be happy to try and answer that for you. So let's just move on. Please write on that for me, Jim. What are the echocardiographic criteria in terms of velocity and gradient to define? Okay, very excellent question, Mr. Anonymous Attendee, or Madam Anonymous Attendee, so I don't know. But the point at issue is, yes, I mentioned this before. Both Steve Sanders and I looked at this to see restriction. If you look at the dimension and divide that by the body surface area, or divide it by the body surface area, and it comes out to be less than 2 centimeters in a subcostal position, that suggests that it's restrictive. And the one thing about restriction is you look at restriction and it's not restriction in a neonate, but the interventricular foramen doesn't grow, so that it can become restrictive even if it isn't restrictive. Our point about looking at the restriction was when there was restriction, there was almost invariably obstruction that occurred in the aortic arch, either interruption or coarctation. So I think that as an echocardiographer, obviously, when you see restriction, you go and look at the arch very, very carefully. And I'd shown you an example of coarctation where this really occurred. This is obviously just part of a complete examination, and it's really an echocardiographic pointer. But I also would remember what Dr. Dick van Praag said about interruptions and coarctation in this situation. He said in interruption and coarctation, all the woe lies below. And what he was referring to was the interventricular foramen and the subaortic obstruction. So that's from Dr. van Praag, and I hope that answers your question. So velocity, yes, velocity, your question about velocity is a little bit more difficult because just as I'd shown you, there was also restriction across the pulmonary artery in the patient that I've shown you. So obviously the 3 meters was not that significant as it would have been if there was no pulmonary stenosis. So it is a variable condition. So any kind of obstruction, 3 meters, I mean, anything above 2 meters, one has to be careful that one's dealing with the velocity obstruction. Now, Dr. Ben Salmani, Yosef, hyperplastic left ventricle in the setting of cor tracheatum sinister with obstructive membrane and AV would be considered biventricular or univentricular. I think the answer is it would be considered univentricular. I think so, especially when you've got a hyperplastic left ventricle. I think that the ventricle is what determines it, but I mean, you know, look, there are many decision strategies that maybe Sasha can talk about. But I mean, this is really a complex decision, and you can't make it just on one echocardiographic picture. But if the ventricle is hypoplastic, I mean, maybe you can consider growing the ventricle. I mean, I know that that's a new hypothesis. And sometimes the ventricles are small, not because they are small because they receive very little flow. And so your question, as I try and answer it, gets more and more complex all the time. So, you know, I think that there was a meeting of the World Society of Cardiac Surgery, World University of Cardiac Surgery. And this was one of the points that was brought up, that perhaps sometimes if you have the right strategy, the right surgical condition, you maybe can try and grow the ventricle. But remember, when you make a poor decision in a univentricular decision and you convert from one to the other, the mortality, which is high anyway, goes up even higher. I think that's correct, Sasha.
Yes.
Okay. And so Jason Tan, hello, Jason. How do you differentiate a Eustachian valve and a divided? Beautiful question. It's a matter of terminology. The Eustachian valve is the quadratum dexter, as it used to be called, and it depends on the size of the Eustachian valve. The Eustachian valve can be so huge that it can give rise to what we call a Chiari remnant or a rete Chiari, and it can occupy the whole right atrium and divide the right atrium, and it can Atresias. In right heart obstruction, the Eustachian valve is usually large. So the answer to your question, Jason, is that they are the same, one and the same conditions. And now I see Adrian Cruchon is here. Good morning, Adrian. Thanks for being here.
Hello. Hello, Dr. Silverman.
Hi.
It was a pleasure to watch your session. This combination that you have of specimen, image, and then loops of echo is just amazing. I only have a quick question about a practical aspect in your experience of how to define, you know, during the continuum between biventricular atrioventricular connection to univentricular atrioventricular connection when you have straddling atrioventricular valves. Do you follow a rule? Do you look? Where do you look from?
I look for a 50% rule. I look for what I think the surgeon can do in terms of septating these conditions. You know, sometimes you can septate them, but I mean, when you get gross, as I showed the gross examples, that's important. I think the most important thing also to look at is the degree of differentiation between the atrial and the ventricular septum. When they are widely separated from each other, it's going to be very difficult to divide them. So I don't have a 50% rule. I must say that, as Dr. Nadis used to say, I've seen somewhat less than 100 of these patients. So we don't have a huge experience at that. But most of the time, the straddling is not septatable, but you know, the minor varieties, certainly they are.
And one practical aspect, Norman, thank you, in terms of how to predict the restriction of the interventricular communication, because for surgeons it's important to either go for a DKS or not.
Right. You know, I mean, this is a kind of an argument and discussion that we would have together on a particular patient in the echo lab with a surgeon. You know, I think it's as you say, you know, this is a complicated question because as you see, it's just not only a matter of the fact that it's small and what the velocity is, but what is going to be the change in dynamics that occur when you change the circulation. And we've seen patients with that the surgeons have just simply done a Glenn shunt on and lowered and this is in the operating room, which I think is the other place where we have to make this discussion, lower the cardiac output of the ventricle, and the bulboventricular foramen, or the interventricular communication, shrinks. And then from a zero pressure gradient, there can be 100 millimeters gradient. I've had this experience with Frank Hanley myself. And he didn't believe me. I said, Frank, you have to go and put a needle into the ventricle to see the gradient. I'm getting 100 millimeter gradient. And he put a needle in and he said, there's 100 millimeter gradient across the outflow tract. So this is a dynamic issue. And I would say, you have to be prepared to do this, but I wouldn't go into the operating room without a transesophageal echo to evaluate that. And I think that's probably the best way, Adrian, for me to answer this question is, take your echocardiographer with you and use him judiciously as you see fit in the circumstance.
Thank you, Norman. Excellent.
Okay, there's a lot of chats going on here. I can go to the chat icon and see what we see in the chat icon.
So the chat, there's a lot of thanks. Thank you very much, Professor. Thank you very much from Arturo Gomez. So again, I think that what is very important, Norman, that my idea that now the 3D reconstruction, the 4D reconstruction, the increasing, the improving of the level of diagnostic tool in this patient can make less intraoperative diagnosis, as you say. So we are really interested in this advance, but I'm sure most of the things that you already told us is amazing and make it daily practice and are very important.
I think that Sasha, I'm an old guy, and I've been around and seen the development of this field. And I think that your point about 3D reconstruction, particularly important in this condition. Echocardiography was at one time, never been a sole technique in the functionally single ventricle. But its place is somewhat diminished. You make the diagnosis and then you have to do sophisticated evaluation. And of course, the problems in terms of the 3D, because basically when you're looking at 3D, 4D, in most of the circumstances, you're dealing with a static image. And there's now 4D flow, where you can look and see both on echo and on MRI, where you can look and see what is the velocity change that occurs across the interventricular foramen. So yes, we're getting more and more sophisticated with the things that we can see, but it's clear that this is a complex group of diseases where fine nuances in the surgical treatment determine dramatically the difference in the life expectancy and complications in these patients. And I absolutely support your potential, but you have to begin somewhere, and usually you begin with a clinical examination, an X-ray, an ECG, and an echocardiogram.
Yes. The point, what I really believe in my not big experience like yours and with in San Francisco, that it's very important, the respect between surgeon and echocardiographists, because this is built every day with every patient, and when the surgeon grow, also the cardiologists grow with him, and on the reverse. So I think that the first period of pioneeristic approach to congenital heart disease is at the end. So now we have, as you say, improved your experience, but it's important This is why I think that this type of lesson is very important, because sometimes we forget the real basic message by the echo, by the simple, or what do we say, first line technique. So I think that your lesson and the message that you give us to spend time to make a real diagnosis, if you have one leaflet, two leaflet, how big is the chamber, how small is the chamber, because again, Damus case stand cell decision, as Adrian say, you cannot do this intraoperative. You can, now you can prepare it, you can discuss it. Your guy Helio Caruso with me, he's growing together. We are growing together, and he's bringing a lot of new technology and new ideas in our field. Yeah. And this is for me the best things. But first, you have to know these things that you are telling us.
Right. Well, anyway, listen, I think this has been a very interesting session for me, and I hope it's been useful for you guys. And of course, we know that it's going to be available on the Congenital Heart Academy website as a lecture, and will be very useful for those people that were not able to attend it, or if they want to pick up some nuances about it, to review the session on the Congenital Heart Academy. So I'll say arrivederci, and I'll see you soon on Friday. Thank you.
Thank you.
Thank you.
Thank you. Thanks, bye, Adrian.
Thanks, Elio. Elio has
thanks, Norman. Sono Elio. Thanks, Norman.
Thank you, Elio.
Thank you. Thank you for the lesson. Thank you for us. And I think it's a very, very, very interesting lesson for fellow, for pediatric cardiologists. And I hope, and I agree with Sasha, we go up for 3D or 4D flow for the surgeon. Thank you, Norman.
Okay, bye-bye.
Bye. Bye, Norman. Thank you very much. Bye, Adrian.
Bye, arrivederci.
Bye, thank you.
Ciao, ciao.